I did want to cover e-referrals because I know that these are occurring not throughout the country yet, which seems to me completely bizarre. It's only another 6 weeks and we're 2020. And the internet started in 1993. We got 27 years of the internet. And how come we have hospital boards that do not yet have electronic referrals? It doesn't make any sense at all. But I'm going to tell you what we do in dermatology in the Waikato. I'm going to talk about the skin cancer epidemic and the fact that there aren't very many dermatologists, as you already know. So melanoma, I've already explained that we have the biggest in the world together with Australia. But actually our age standardized rate, people talk about more and more melanomas, but actually there aren't. We have the same age standardized rates now that we had 20 years ago. We can't tell you before that because, or not before 1994, because the statistics weren't collected before 1994. But they have been since then. And we have the same age standardized rate. But there's a 71% increase in melanomas because we have a bigger population and we have an older population. So 1994, we had a population pyramid. And now we have a population pyramid. It looks a bit different. So if we looked at the 65 to 69-year-old age group, we now have twice as many people that age group than we did in 1994. I've just chosen that age because it's an age when people get quite a lot of cancer. You know, in your 60s. So if you're getting skin cancer in your 60s, the other thing we know is you're going to live quite a long time. And you're going to, if you're already getting them in your 60s, how many are you going to get in your 70s and how many in your 80s? And so this burgeoning population of older people is a real problem in the skin cancer world. And some people have literally hundreds of skin cancers. So this was March 2018, but we started looking at the crisis in dermatology much earlier than that. And in 2012, we did a workforce review. I was the president of the New Zealand Dermatological Society at the time, and I commissioned a review of dermatology services for the year 2020. And it was done through Workforce New Zealand and the Ministry of Health. And it's published on the Ministry of Health's website, and you can read it. And it basically said, for the year 2020, we need 4 times as many dermatologists. And of course, that hasn't happened. So in the Waikato, we have 2.3 full-time equivalent dermatologists for our local population, but we're a tertiary institution, so we cover 900,000 people. We have a similar population to the rest of the country in terms of age span. Now, if we haven't got enough dermatologists, it's likely that skin cancer is going to be diagnosed later, because it's not always easy to diagnose skin cancers. And we also know, because people are so determined not to miss melanoma, that there are many, many, many thousands of unnecessary surgeries. So I've made it my life role to encourage training in diagnosis of skin cancer using dermoscopy, because with dermoscopy we can be so much more accurate. And we've now trained thousands of GPs and practice nurses and other people in diagnosis of melanoma. And people who are trained in dermoscopy initially are worse than they were before. So it takes practice. Training isn't enough. You've got to practice, and you've got to learn from your own mistakes, and you can only do that if you take photographs. So it's really important to take photographs. But once they've got the hang of it, they have lower benign to malignant ratios, which means they cut fewer things off that didn't need to be, and they diagnose earlier. so that they're removing melanoma in situ rather than waiting till it's invasive. Teledermoscopy is the use of information and communication technology to consult an expert. Well, we do that through the internet these days. In the old days, it was called a telephone. You know, you'd pick the phone up and talk to someone. Don't do that so often now, but it still does happen. This is my current team. This is us doing our teledermoscopy work in the clinic at Waikato Hospital. We've got 3 computers going, and we've got 2 big screens on the wall. Because it's a teaching clinic, you can't see them, but there's medical students and other doctors every single Friday afternoon. So we're teaching as well as doing an active clinic. So one of our clinics is about to stop, but this is virtual lesion clinic, and we've been doing this since January 2010. We tried about 10 years earlier than that, but it took us 10 years to get it established. We've had 8,000 patient visits, 13,000 lesions. It's lesions, not images. Got that wrong. Be 4 times as many images. We've got centres in Hamilton, Thames and Te Kuiti. So if you're invited to one of these, you go and have your lesion photographed. So this is on GP referral. So we received the referrals. In the old days it was by paper. Now it comes through the computer. And we allocate the patient to be imaged at one of the imaging centres by a nurse who's trained to do it. They take a standardised history and they take the most beautiful photographs, which is what we look at on the Friday afternoon, or what we used to look at on the Friday afternoon. This you don't need this technology to know that's melanoma. But it's a nice example of how the macro picture is totally different from the dermoscopy picture and makes it easier for you to understand that we can see more with a dermatoscope than we can with the naked eye. Because a benign lesion might look like that and turn out just to be a seborrheic keratosis. It looks quite different. Very accurate. Our benign to malignant ratios are 2:1 for lesions suspicious of melanoma, which is as low as you can get anywhere in the world. We reduced the wait time from 3 months down to 1 month, and we reduced the costs. But we're still keeping people wait an awful long time. 34 days is ridiculous. Patients still have to travel because we've only got 3 places. And it's run by MolMap, so the data is held on MolMap computers, and although there's a PDF, it's not on the GPs or the hospital, apart from the PDF report. And so it got very, very popular. We got more and more referrals. We were getting more than 50 referrals in a week to the service. We had a lot of fun. We educated a lot of doctors and students, but then it dropped off. And we've got down to about here now, and the service will be discontinued on the 31st of December. So it'll have a replacement. So e-Triage is the electronic medical referral system, and in dermatology that began in 2016, beginning of 2016. And we don't receive any paper referrals at all, 100% electronic. So the GPs, so what happens in the hospitals, they're still paper-based, but they get converted into a PDF. We receive them electronically. But GP referrals are done from the practice management systems, and they can attach files. So we can decline a referral. So we've always been able to decline referrals, but we didn't like to because it took us so much effort. If we accepted a referral, we just ticked. If we declined it, we had to pick up a telephone or dictate a letter and explain why. So we hardly ever did that. So we accepted everything, and people waited for up to a year to be seen if they were seen at all. Then the ministry said, that's not good enough. You've got to see everybody within 120 days. So we had to invent something else, which was called declining people. But we just declined, and we didn't send you a letter. We just declined. So you had no idea why we declined because it was pretty random at the time. But now we decline with this button, return to referral advice guidelines. So that means we actually have to tell you why we're declining. And this is a Ministry of Health idea. So we encourage our GPs to not refer for an appointment, but to refer for advice, and nearly all our referrals now are for advice. We get very few for appointments. Good. We have no appointments. So a GP's point of view, it's what they do all day. Much of the data is just popped in automatically. From the dermatologist, it's recorded in our electronic medical record, and we avoid seeing people as an outpatient. When I say we have no appointments, did you hear what I said? We have no appointments. And I mean that. We are fully booked 6 weeks ahead, but we could be booked a year and ahead. We only booked 6 weeks ahead because that's the rules. You're not allowed to book more than 6 weeks. We have nowhere into the next 6 weeks. There is no appointment. Why would we not want to do it? Well, it takes much longer. I used to just tick, okay, 2 seconds. Now I have to type all this stuff. I have to think. The history from the GP is variable. So it's lesion, please see. Or patient concerned. Well, that's not much use to me. And although we were getting a few pictures, most of them are pretty unhelpful, really. And so we did some research and we looked at the quality standards, which is a British qualification, and we audited skin lesion referrals. We're just talking about lesions here, for a 3-month period. And we discovered that there were 204 referrals in that time. They were poor quality, there was lack of information, and only 17 referrals included images. We did some publications from that. So that shows you what lack of quality was. So the good bars that tell us that the GPs did tell us the patient's date of birth, because the computer does that for them, but they didn't tell us how long the spot had been there, which is actually important for diagnosis. And the images, they were pretty poor quality, the ones we did get. And so on the 1st of July 2017, we started a new template where we compulsorily got people to answer certain questions like, how long has it been there? And we gave training, provided online training, had various initiatives, evening meetings and so on, to introduce this. And it was an initiative that actually came from primary care. We'd been trying to do it from dermatology and got nowhere. But finally, primary care took over and said, right, you haven't succeeded, we're going to succeed. And primary care allowed us to do this. And so we receive a referral list, and these ones here were the normal dermatology referrals, and this would be through the suspected skin cancer pathway. And this is totally out of date. This is 2 years old, which doesn't look like that anymore. And you can tell how many images by the number. So grey means it's for advice and the images. And then orange means urgent, and yellow means semi-urgent, and green means routine referrals. So currently we receive about 500 referrals per month, and nearly all of them are grey. And because the GP knows they're referring for advice, we are getting the information we need to give that advice. So the very first one on the 1st of July, the very first referral, skin lesion suspicious of skin cancer, patient wants this removed. I'd appreciate an opinion. I am not convinced. That's a melanoma, and was proven to be melanoma in situ. This was before the last time I gave this talk, on the 27th of May, so it was the immediate one before that this year. And what the referral looked like in May, it's changed again. It doesn't quite look like this now. Get dermoscopy referred to a dermatologist, images of right hand uploaded. So this is actually by a nurse. So most of our referrals now are a combination of GP and practice nurse done. So the GP might see something he's suspicious of, and then the patient is either immediately seen by the nurse or booked with the nurse, who takes the standardized history, fills out our template, and takes beautiful photos. Most of these are done very, very nicely. So now we get the photos we want. So this was randomly selected as being the most recent referral on the day that I did that talk. So it's adequate for diagnosis. So it's not brilliant photos, but it's adequate. So we get where is the lesion and what does the surrounding skin look like. That's called a regional or anatomic view. Essential, we need that. Second, we get a close-up. So we can see it's a scaly plaque or a nodule. And then we get the dermoscopy. And with that combination, we can say that's a squamous cell carcinoma, cut it out. Now, if all I got was a dermoscopy, I'd just say that's a scaly spot. Couldn't diagnose it. Need all three. So after we'd done this process for 6 months, we did an audit. There were 340 referrals in that 6 months' time, 402 lesions. The bars were all much higher. Different students, so it's a different poster. We got good information, rapid response. The mean was 1 day, no more than 4 days. So the responses were getting back within 24 hours. And what really surprised us was the GP diagnosis was concordant in 25% of referrals. So that meant 75% the expert disagreed with the referring doctor, which we felt was a very good reason for having this service, because we do believe we know what we're doing in dermatology. We might be wrong, but we have done a number of audits to help us with pathology and that sort of thing. We've done quite a lot of work on this now. So we then looked at the quality of the images that came in that 6 months. 27% had followed the instructions. We got all 3 sets of images. 50% at least had given us 2. And 23% only sent us a single image, which, as we've said, is sometimes adequate, but often isn't enough. We need all of them. And so we got another poster of the quality of the images. 78%, that's supposed to be 2,000, not 200, where the quality we require. But we still get a small number of tiny little images. Well, if you can't diagnose from a tiny image, I can't either. So we need a big image. And it would be helpful if it was in focus. It's not that hard to take an image in focus with modern cameras, and only a quarter had a neutral background. A busy background really interferes with my ability to diagnose. Please use a plain background and use flash. We're in dark rooms like this one. Your camera is going to struggle to get a good picture. It's going to do its best, but those pictures are going to be pixelated. They're not going to be as good as if you have good lighting using flash. So there's different devices. Most of them turned out to be Apple devices that people were using. They were using iPod Touch. They were using iPhones. They were using mini iPads. And there's some Samsungs and other things as well. But almost nobody is using a standard camera anymore. We got more referrals. So the current process, if you've got you come to your GP, you've got a lesion of concern, the GP says, I need help here. He could send you to the hospital, to private practice. If you go to the hospital, you could go to dermatology, plastics, or some other service. If you go to dermatology, you could be given an appointment in an outpatient clinic. You won't get one because there aren't any. You could go to the virtual lesion clinic, which is this referral service that's imaging in one of 3 centres, or you can send us the specific template and include the images. And you're going to get an answer back, guaranteed within 5 days and nearly always within 24 hours. So we looked at the people attending the outpatient clinic, and we have an acute service, which means you'll be seen in less than 2 weeks, a semi-urgent 45 days, and routine. And the only one we've actually, I said no appointments, we've kept a few for acutes, because acutes have to. So we have a dedicated registrar whose work is acute. So there's 2 registrars, so they swap round each week. So you have to be just about dead to get one of those. 5,000 referrals up till April. 1,135, or 22% of all the referrals came through to our suspected skin cancer service. And those are the other sort of things we were seeing. So we did another audit. And we compared the 2 years. And what we learnt was quality had got better. The diagnosis still remained the same. We were seeing melanomas, basal cell carcinomas, squamous cell carcinomas. And some of them we can't make a diagnosis. We can't make a diagnosis of everything because that's impossible. Some of that was because of poor quality referrals. We've stayed very, very fast. So in March, there were a few more a little bit later, but still seeing 75% on the same day of referral. So why would we do that? Well, it's the GP's usual system. You get an answer back really fast. It's incredibly educational. We get a lot of feedback from the GPs saying, thank you, I learnt so much. In fact, those GPs increase their number of referrals, level off, and then start to reduce because they think, oh, that's the same as the one I sent last year. I know what to do. I don't need to refer that one anymore. We like it because finally we are paid to do it. Okay, so Monday afternoons I don't work at the public hospital, but I'm paid to do e-Triage as an extra because somebody has to do it. Well, I should be doing that now. Problem. But triage takes longer, so we know that for the skin cancers we can do 10 in an hour if we're not teaching, on average. But if we're doing rashes, and we've now introduced rashes, we can only do 5 or 6 an hour. So it takes longer. The software is really clunky. If we had decent software, it would be much faster. But they don't invest in IT. They just pay us, which is silly, really. Image quality remains variable. Now, we know we're missing skin cancers, and my colleagues in other centres will shake their heads disapprovingly at the Waikato. They say, why are you doing this? This is bad medicine. They're still saying that now. The reason it's bad medicine is we are not examining the patient from head to toe. We're expecting you to do that. GPs, practice nurses, examine the patient from head to toe. Send us the pictures of the things you don't know what they are. So why is it good? Well, it's very fast. We're reducing the number of excisions. It's very difficult to quantify because the data's impossible to collect because people remove things for all sorts of reasons. And unfortunately, they don't write it on the request form. So we did a limited number. We looked at 400 request forms to see why the lesions had been removed. Most of them were benign. And we were thinking, well, why have they removed a benign lesion? And we don't know. Were they suspicious of melanoma? Who knows? This is some of the team. Unfortunately, Dr. Jung died last year. Lots of students have been barred. So I thought we'd talk about how can you take good pictures to add to your referrals. We used to use the map of medicine. This has been killed off now. We're using health pathways. But I've kept it in this talk because it explains the pathway. So you click on each of these and you get more detailed information. So it was to enable our referrers to find out how to take pictures and when they should be taking pictures and what sort of pictures they should be taking and when they should refer straight to plastics and when they should refer to us. So there's pathways. The information about taking pictures is written here, but it's quite straightforward, really. We need all those 3 pictures. So the close-up is from 20 centimetres. Don't go closer than that because it's going to be out of focus. We need a plain background. You attach it to the e-referral. Now you've got to talk to the patient about this. You can't just take pictures and say, no, you have to get consent. And it's very rare for a patient to refuse consent. Our lawyers have said if the patient refuses photographs, you can refuse to accept the referral. That's a problem, isn't it? We have no appointments, right? Where are we going to put them in? They have the choice to go privately. Sequential dermoscopy imaging. So sometimes we'll say, not sure, take another set of photos in 3 months and send the old ones and the new ones to us because we can't see what we sent you before, so we need them sent again. Then it was talking about whose camera was it. So many centres in the world that are doing something similar to this, and there aren't many actually, there's a few centres in the world doing something similar to this, they've often given the camera and the dermatoscope to the GPs. They've said, here you are, here's the package, you have it. Well, we chose not to do that. And I think we did the right thing. Because my colleagues in overseas say the problem is it's not the practice's camera. It breaks, gets abandoned. Nobody charges it. It gets stolen because they don't put it in a cupboard because they don't own it. So that's one thing. And secondly, they may say, I don't like it. I didn't choose it. I would have chosen a completely different model. So we know that cost is a problem. So very often the practice rather than the individual doctor or nurse is buying the equipment. But we also know that you don't have to spend very much money. Now, I did mention $30 for a dermatoscope. Please don't use that one. But there is one that costs only $120, which we're receiving fabulous pictures from that. It's called a DermLite Hood, HUD. It's a polarized contact dermatoscope, fits onto various different devices, and gives us good quality pictures. And I think most practices could probably run to $120 for a bit of kit. And it's you just charge it, the light, in the computer. And which device do you use? So a lot of problems with security and things. I've not got time to talk that because I could talk about security for the rest of the day. Each individual practice is going to have to work that out for themselves. But there is no reason in 2019 why you shouldn't have a secure system. In our hospital, we now have a system where we can take the pictures on the cell phone and it gets whisked off the phone and it lands in the electronic medical record immediately. So I take that picture and I look at the patient's file and it's already got the picture up there. You can do that in general practice too today. It's just that people don't. It's another effort.